So we made a lot of improvements in the prediction of outcome in the non-transplant and non-transplant setting for patients with myelofibrosis. So first of all, there was these driver mutations that informed us that if you have a non-CALR genotype, specifically JAK2 genotype, you have worse outcome. This is also true for the transplant setting, where you have a non-CALR but now also non-MPL genotype, you have worse outcome after transplantation. So this gives us an information about the genotype and the typical risk after treatment, but also from diagnosis. And then what we found out, and which was then incorporated into a transplant-specific score, was the addition of the ASXL1 mutation, which together with the driver mutation genotype also informs our outcome. What we now have the problem is that we know that some mutations like the K-Ras or in general the Ras mutations, they seem to be associated with a little bit of more of a proliferative disease, but there are too few patients. So when we talk about the role of these mutations, we need to talk about like more subtle endpoints, like how do we define accelerated phase, and then go from there and say, okay, accelerated phase is usually associated with a higher risk of relapse, etc. So obviously it is of importance to include these mutations in the workup for transplant, but also from diagnosis. And if these patients have these mutations, maybe together with other risk features, with a certain age, with a certain disease phenotype, then obviously we need to take this into account and consider them early for transplant, to not have them go into a full-blown relapse, which obviously accelerated phase patients are at higher risk to get.